be a little challenging. Just make sure you take your time to read the question. That's the advice I have for you. Okay. All right. So today we're going to be covering hair and nail disorders. So this is a very quick lecture. So you guys have plenty of time to go study after this if you don't have much else today. Okay. So we have a bunch of pathologies we're going to be going through. By the time we get to the nail stuff, that's where everything's going to move really quickly because some of the nail disorders just are what they are, and there's not really a whole lot to say about them. Okay. And then we're going to review some anatomy instead of going over any definitions today. So first, I just want to bring your attention to the anatomy of the hair. So this picture here is that classic cross-section of the skin, which I know you guys know, all right? But what I just wanted to show you is that if you follow this top layer, right, the epidermis, all the way down to this darker line, that is the basal layer, okay? And if you trace it all the way around, you'll see that it goes around the sebaceous gland and then around this hair here. That's what makes up the hair follicle, okay? It's actually an extension of the epidermis that's diving down deeper into the dermis and sometimes the subcutaneous fat layer. Just want to show you that's where the hair follicle comes from, okay? Within the hair follicle, obviously you're going to have a hair, right? So you're going to have the hair bulb, okay? The hair shaft as it goes up and through the skin, all right? The hair is going to be made up of hard keratin, and there are 3 layers to the hair, okay? The inner layer being the medulla, followed by the cortex, and then the outermost layer is going to be the cuticle, okay? Little fun fact, so the cuticle of the hair is actually made up of keratinocytes that are flattened, and they kind of layer on each other like shingles on a roof, okay? So a little different, okay, in the way that our cells are structured there. All right. Here we have a hair within the hair follicle, okay, just a cross-section of it. So I just wanted to show you guys again, this is going to be the medulla being the innermost layer, the cortex just outside that, and then the cuticle outside of that, all right, for our hair layers. And then outside of that, okay, you have the internal and external root sheath. So this is just another layer of protective cells, okay, that's going to protect their hair and also give it shape, okay? Then we have the hair matrix, okay? So the hair matrix you should kind of liken to the basal layer, all right? This is where all the stem cells are going to be that are going to give rise to the keratinocytes that are going to make up the hair, okay? And then also within this layer, you're going to have melanocytes, okay, that are going to produce melanin, which is going to give pigment to the hair, okay? Also similar to the basal layer, the hair matrix receives all of its oxygen and nutrients via diffusion from the dermis, okay? So this area here, this is part of the dermis. This is the hair papillae or dermal papillae, all right? This is the vasculature that is going, or it contains the vasculature that is going to give oxygen and nutrients to that hair, okay? That's where it comes from. All right, that's pretty much it. Okay, let's talk about the hair growth cycle. So depending on which textbook you're reading, the hair growth cycle is broken up into either 3 or 4 phases, okay? If it's broken up into 3, which is the way we're going to be talking about it today, it's just that the 3rd phase has like a secondary part to it, okay? So it's not just telogen, it's also exogen, all right? As part of that phase, kind of, okay? But I mentioned it anyway, so you might see it in the literature as those 2, phases being separated from one another. Right? Okay. So the hair growth cycle. So all of our hairs that we have on our body are going through their own hair growth cycle independently, which is actually a great thing. Okay, because if they were all doing it at the same time and going through each phase at the same time, we would have periods of time where we would have hair on us. Okay, we have a full head of hair, and then times where we would be completely bald. All right, so thankfully they're all kind of doing their own thing as they go through their cycle. All right, this is also particularly important when we think of like thermal regulation and insulation, right? So, it's nice that we're able to retain hairs in different phases. Okay, we're not losing them all at once. All right, so let's take a look at the first phase. So this is going to be our anagen phase. This is active hair growth, okay? This phase typically lasts between 2 and 6 years, And about 85 to 90% of our hairs are going to be in this phase at any given time. Okay. Now, because this is active hair growth, okay, and it's a pretty long phase, this is what's going to determine the length of our hair. Okay. Now, I wanted to show you guys this picture here. So, what's important to know and kind of make anagen make a little bit of sense is the fact that it is a hair growth phase, and it's a hair growth phase because the hair is attached to that hair papillae, okay, or that dermal papillae. All right. So it's actively receiving oxygen and nutrients to supply, everything the cells need to continue growing that hair. That makes sense? Right. Okay. So that's your anagen phase. Okay. Then you have your catagen phase. This is considered a transitional phase. All right. It lasts about 2 to 3 weeks, and about 1 to 3% of our hairs are going to be in this phase at any given time. All right. It's considered a transitional phase because we're going from anagen, which has a lot of mitotic, activity, to decreased activity in catagen. All right. And then eventually you're going to have cell death. Okay, so we're transitioning from a lot of growth to nothing happening at all. All right, and there's a reason for that. Okay, and the reason the cells die off is because if you look at this picture here, you can see that the hair has moved away from that hair papillae, right? So it's no longer receiving oxygen and nutrients. The cells can't thrive. Okay, and the reason that happens is that the hair follicles start to atrophy. All right, that's what's happening here. Right? And it just naturally squeezes the hair away from that dermal papillae. All right. Okay. Then we have our telogen phase. So telogen is considered like a resting phase. Okay. It lasts about 3 months, and about 5 to 10% of our hairs are going to be in this phase at any given time. All right. Now it's considered a resting phase because that's what the hair is doing. It's just resting within the follicle. It's just sitting there. Okay. What's notable about it is that the shape of the hair's root changes. It becomes a club root. It becomes more rounded. Okay. And the reason that happens is because we want to keep our hair. So it helps anchor the hair within the hair follicle. All right. Again, think of like insulation, thermal regulation. We don't want to lose these hairs. All right away. We try to retain them for as long as we can. Okay. All right. After telogen, then exogen occurs. Okay. Exogen is going to be where there is active hair shedding. Okay. It's where we actually lose our hair. But the reason that we actually lose our hair is because we're moving back into anagen, and a new hair is growing, pushing the old hair. Right. So that's why that happens. All right. So we pretty much covered everything on this slide. The only thing I wanted to draw your guys' attention to is the photo on your right, okay? So something you can do is called a hair mount, all right, when you're trying to create a differential diagnosis or trying to figure out what's going on with your patient. And essentially what you do is you pluck a couple of hairs and you put them underneath the microscope and you evaluate them to see what phase that hair is in, okay? And if you can figure out what phase the hair is in, you can kind of narrow your differential to pathologies that happen, say, in the anagen phase, or pathologies that happen in the telogen phase, okay? So let's talk about what the difference between those hairs would look like and how you'd be able to tell, all right? So this image here, okay, the one labeled A, this is an anagen phase hair, all right? I know it's an anagen phase hair because it has a malleable root, okay, or proximal end. That's just the shape of it here, all right? It's also diffusely pigmented, all right? So that tells me that this hair had to be attached to that hair papillae, okay? Oxygen and nutrients had to have been received by the cells because the melanocytes were active in producing melanin, all right? Melanin is what's gonna cause pigmentation of it, all right? So you look for that, a pigmented hair. And then on the outside of the hair shaft, okay, there's that clear structure. That's the internal and external root sheaths. All right, they're still present. Okay, they haven't atrophied away yet. This is an anagen phase. Okay, as opposed to the image here, B. Okay, so this is going to be a telogen phase hair. All right, I know it's one because it has that clubbed root. All right, There's no internal or external root sheath. It's atrophied away. And it's largely depigmented, okay, because the monocytes are inactive. All right, they're dead at this point. Make sense? All right. That's pretty much all I'm going to say here. Okay. Different types of hairs. So we have lanugo hairs. All right, so these are going to be fine pigmented hairs that usually cover a fetus. All right, they're shed usually before birth. Sometimes they are retained on the baby after they are born. They last about 2 to 3 weeks, and then they are shed off. All right, the reason we have these hairs is because they protect the baby. Okay, they help with, again, thermal regulation and insulation. All right. Now, sometimes as adults, you can see these hairs return, all right? And that's going to be with individuals usually who have malnutrition, okay? Or an eating disorder, say maybe like anorexia nervosa, all right? The reason for that is because these individuals don't have fat stores. They cannot insulate well. So the body tries to compensate for that, and they produce more lanugo hairs, okay? So it's something you might know in this patient. Right? Otherwise, in someone who doesn't have an eating disorder, who's not malnourished, you don't usually see them again. Okay, vellus hairs. So these are going to be fine, non-pigmented hairs that cover pretty much your entire body. Think of it like peach fuzz on like the face, okay, for example. Then we have terminal hairs. So these are going to be thick pigmented hairs that you're going to find on the scalp, on the eyebrows, the eyelashes, and then you'll see them in secondary areas after puberty. Okay, they're going to be, greatly influenced by our hormones. All right. Okay. So when it comes to evaluation of our patient who has hair loss, the first thing that we're going to want to do is we're going to want to take a history, right? We're going to talk to our patient. I think one of the most important questions you can ask your patient is, where are you noticing your hair loss, right? It might be obvious because they're going to say to you, it's on, say, my scalp. Okay. My next follow-up question is, have you noticed it anywhere else? All right. That's an important question because it can help you figure out the severity of what's going on with your patient. All right. Hair loss doesn't just happen on the scalp. Okay. It can happen in the eyebrows, in the beard, on, an individual's legs. All right. If I'm noticing it in multiple areas, they probably have more of a severe pathology presentation going on. All right. So it's important to ask that. All right. Or if they're noticing, a patch of hair loss on their scalp, is it just there or is it in other places too? And then you'll realize that patient's, oh yeah, no, I didn't just see it here. It's actually over here and here too. Okay. So just good to get that history. Right? Then you're going to look at your patient's area of hair loss. Let's say they're, having hair loss on their scalp. They may have a widening part. Okay, that could be natural with just age. All right. You're going to look for any rashes or lesions that may be on the scalp. So any erythema or scaling. You're going to look for characteristic signs of pathology that could cause hair loss. Maybe they have like a tinea capitis or something like that, a fungal infection on the scalp. Okay, you're going to look for that. You're also going to look down at the scalp for any areas of scarring. Okay, so this is where you don't see any little dotted follicles in their scalp. Okay, it's just going to look completely smooth, the skin. This is an important detail, okay, because it's going to help you create a differential diagnosis based off of scarring alopecias. Okay, so it's an important thing to know. All right. There are tests you can do, like the hair pull test. Okay, so essentially what you're going to do very, very gently, okay, we're not going to be rough with our patients, so you just kind of grab a couple strands of their hair. You're going to do that in a couple of different places around their scalp, okay, don't tug, just a gentle pull. All right, and when you do that, you're going to try to collect some hairs. If you collect more than 3 to 5 hairs, there's likely a pathology going on, okay, and we'll talk about when we're like a lot of hairs, like clumps of hairs, okay, when you check your patient. All right. You can do a hair mount, as we discussed before, okay, where you're looking for anagen or telogen-phase hairs, okay. There's actually even something called a trichogram, which you could take 50 strands of your patient's hair, just kind of pull them all out at once, and try to create a ratio of anagen to telogen hairs to determine what type of hair loss you are seeing, okay. So that's something else you can do too. Biopsy. So this would be a punch biopsy into the scalp. All right. This can help you, determine pathogenesis and help you with your differential. Okay. Serologic testing. So there's some blood work that you could do for your patient. This we'll talk more about as we go through the pathologies, but it could be like doing an iron panel. Okay, as iron deficiency anemia can lead to hair loss. It could be checking your patient's thyroid. Okay, checking an ANA. All right, to see if there's an autoimmune cause behind their hair loss. All right, so you may have to do a workup depending on what's going on. And then there's patient-based testing. So there's something called daily counts. All right, where essentially you're going to tell your patient to go home and clean out a brush that they routinely use. So they remove all the hairs from it. And then all they're going to do is brush their hair, okay? And then they're going to count how many hairs are within that brush, okay, that they collected. If they collected more than 100, then that's likely pathology. Okay, that would be too many hairs. All right. A lot of patients will do this on their own, like they'll just naturally, check and see how many hairs they've lost after brushing their hair, and they'll come in with a little baggie and they'll say, "Look, hair." All right. So, that's not uncommon for patients to do that. But if they haven't, something you can tell them to do. All right. Okay. So the first type of hair loss we're going to be talking about today is androgenetic alopecia. All right, so this is kind of perfectly named for what it is because it's going to be based off of an androgen, okay, that's going to affect genetically susceptible people, okay, and it's going to cause alopecia, baldness, all right, and based off of whether someone is male or female, there's going to be a certain pattern to their hair loss, okay. So the androgen that we're talking about is DHT, all right, it's a derivative of testosterone. Okay, testosterone is converted to DHT by an enzyme called 5-alpha reductase. I mentioned that because one of the medications that you utilize stops that enzyme, stops the conversion to DHT. Okay, and what DHT does in these genetically susceptible individuals is it binds to receptors on the hair follicle. Okay, and it turns on certain genes, which is going to lead to a certain pattern of hair loss, right? But in addition to that, it causes miniaturization of the hair follicle. Okay, it causes it to get smaller and smaller and smaller over time. Okay, so it does this by shortening the anagen phase, that growth phase. Okay, so you're going to have someone who goes from like normal caliber hair to over time having hair thinning as their hair becomes more vellus and very fine, till eventually it affecting the cells so much that they die off, and then you have permanent scarring that you see with hair loss, okay, of this type. All right, make sense? Yeah? Okay. All right, so let's talk about what happens with females. So this is going to be a Ludwig classification, okay, for females who have androgenetic alopecia, and it's graded on a scale of 1 to 3, okay? So with females, what usually happens is you're going to have retention of the frontal hairline, okay, and then diffuse hair loss behind that to the vertex of the scalp. So right back here, all right, all just kind of diffusely lost, all right. As you get to grade 3, obviously this is going to be more severe. And to kind of put it into context, this one here is a Ludwig classification of 2. And then here, this is the classification of 3. Okay, so you can see with 3, you're looking directly down onto this individual scale. Okay, all right. For males, it's the Hamilton classification. Okay, and this is going to be graded on a scale of 1 to 5. So when males have this particular pattern of hair loss, you're going to have bitemporal loss first, okay? That's going to worsen over time. Eventually, it's going to affect the frontal hairline, okay? At the same time, you may also have loss over the vertex of the scalp, and then these areas are kind of just going to coalesce together, all right? And eventually, you're going to be left with this pattern here, okay? This is called the Hippocratic wreath. This is where you have retention of the hair follicles just around the temporal area and the occipital area, okay? So you might wonder, well, why, right? Why is it that just these hairs in these areas remain and the other ones are gone, right? That's because hair in this distribution is not affected by DHT, okay? So they're able to remain, okay? This is why when we do hair transplants, we take from these areas from these hairs here and transplant them to the affected area. And we're not worried about failure because they're not going to be affected by THC. Okay.
Why is it not affected by these?
They're just not susceptible to it. It just doesn't, the hormone doesn't affect these hairs.
It's like different
Receptors, yeah.
Changes that.
Yep, just this area. Now that those hair follicles won't be affected by THC.
What's the word?
This, like this.
So,
I think it's
sorry. If like someone were to get like a hair transplant, like at the top, like would that mean that that hair would also get affected by DHT over time and
No.
it would fall out again?
No, that's why we don't worry about it. Yeah, we can just take these hairs and transplant them and then
Thank you.
they can fail for other reasons, but not because of that.
For men that go completely bald, are the hairs so here for them susceptible to DHT levels?
So some of that can also just come with like age and losing that hair, but the hairs usually remain. Yeah. Okay. All right. Question for you guys. What do you think is going on in that top left picture of that woman's scalp? There's a red spot. Mila, you're right. Sorry, guys, I missed that. Top right. It's a red spot.
Cancer?
Cancer, yes. Exactly. So that's a squamous cell carcinoma, okay? So I just wanted to highlight the fact that when you have someone who has hair thinning and hair loss, you want to make sure that you're checking their scalp. The sun can easily irradiate these areas. It's caused skin cancers. It's a good place for precancers and skin cancers to pop up. Okay? All right. So make sure you check. Okay. So this is going to be the most common type of hair loss. All right. Something important to note too is because this is a genetic condition. All right. There is always a family history. So it can either be through your mother or your father or both that someone could inherit this. Okay. So you want to ask about it. It's going to help kind of back up your diagnosis. All right. When it is positive. Okay, so for men, this is going to show up sometime after puberty, usually around age 20 with full expression by age 40. For females, this is going to show up later on in life, usually around age 60. It's less common in females than it is in males, okay? In terms of your patient's symptoms, so it's typically asymptomatic, all right? But it can certainly cause anxiety in your patient, okay? And I think that's fair, right? If someone's losing their hair. So you want to make sure that you spend time with your patients who are experiencing hair loss, whether it's androgenetic alopecia or another type with counseling, all right? Okay, so when it comes to diagnosis, so for men, it's going to be clinical. You're going to ask about a family history. That's going to come back positive. All right, you're going to look at the pattern of hair loss. And then from there, you'll just be able to make the clinical diagnosis, okay, and get them on treatment. For women, because this happens later on in life, usually, again, like around age 60 or so, there's a lot of reasons that someone could have hair loss. You're going to want to do a workup for them, okay? Especially because this type of hair loss is not that common, all right? So you're going to check their hormone levels, okay? You're also going to check their thyroid function. You're going to check an iron panel, okay? Again, for that iron deficiency anemia. You'll also check them for an ANA for any sort of underlying autoimmune disease. When all of those come back normal, okay, then you can assume that your patient has androgenetic alopecia, okay? All right. So for treatment, so for men, it is going to be Rogaine as an option. This is going to be 5%. It's over the counter. It comes as solution. It also comes as a foam. It's usually used twice a day. All right. You have to let your patients know it takes time to work. Okay, like 12 to 18 months before we can assess full efficacy of this medication. They'll start to see some results by like 4 months or so, but full results within about a year. Okay, so they have to be patient, be diligent, and keep using the medication. They can't stop. They got to be consistent with it. All right. With that being said, side effects to minoxidil. So sometimes it can cause itching or burning on the scalp. All right. And then one of its notable side effects that you want to make your patient aware of is that it can cause increased hair shedding initially. Okay. And that usually stabilizes around 2 months. All right. Which might seem scary to your patient. They're going to say, I'm using this and my more hair is falling out. Okay. And then they're going to be resistant to using it. It's actually a good sign. It means the medication is working. All right. The way that minoxidil works, okay, or Rogaine works, is that it acts as a vasodilator. It promotes the anagen phase, okay, by providing more oxygen and nutrients to the cells, okay. So hairs that were in telogen just naturally are going to be shifted into anagen with this medication. This anagen starts, exogen happens, right, and pushes out the old hairs, okay. So it's just a sign that it's working. Does that make sense? Yeah? Okay. Good. All right. So you want to make them open. Finasteride, okay, also called Propecia, is going to be another medication option for your patient. All right. It's an oral pill, 1 milligram. It's taken once a day. All right. It works really well because it's a 5-alpha reductase inhibitor. So it stops that enzyme that converts testosterone. Okay. Studies show that it can decrease DHT levels in the serum and then the scalp by 60%. So it's a nice medication. With that being said, one of its major side effects is something you have to let your patient know about, is that it can cause sexual dysfunction in 2% of males. Okay, so you want to let them know that before they start the medication and make sure that they agree, okay, to using this. All right, this is considered category X in females, so we typically don't get it. Now, for women, it's going to be over-the-counter minoxidil 2%. Okay, so a slightly decreased percentage, okay, of the medication. It's going to be applied in the exact same way as described for men. Okay. Other options, hair transplants. Okay, so that could be something you consider for your patient who's had type of hair loss. PRP. Do you guys know what PRP is? Yes, no? Okay. So PRP is platelet-rich plasma. Okay. Basically, the procedure for this is that you draw your patient's blood, goes into a little tube, right? You put it into a centrifuge, you spin it down, okay? It's going to separate out the platelet-rich plasma, okay? That has growth factors in it, okay? You're going to put that into a syringe. You're going to inject it back into your patient's scalp, okay, in the areas of hair loss. The idea is those growth factors will stimulate the hair follicles to start producing hairs again. It is not covered by insurance. It is very expensive. It takes multiple treatments, okay? And I would say results are variable, okay? So it's something you can certainly try for your patient. May or may not work for them, but if they're motivated, they might be willing to give it a go, okay? So it's an option for them. Hair pieces, okay? So like wigs and things like that can also be utilized. And then hair powder. So hair powder is a powder that matches your hair color. Okay, and what individuals will do is they'll just kind of drop it onto their scalp. It'll kind of camouflage the skin of their scalp and help the hair kind of blend in, all right, hiding that area of hair loss, okay? So for someone who has more mild thinning, that might be an option for them, okay? All right. Alopecia areata. So alopecia areata is going to be an immune-mediated type of hair loss. Okay, that typically happens after some sort of stressful event. So it could be like an infection or something like that, but oftentimes I would say it's more correlated with like an emotional stressor. So that could be like someone had a change in a job or loss in a job, right? Maybe a loss of a family member. If we see this in kids, it could be that they changed schools, okay? And that stressor kind of triggered for this condition, all right? So with that, alopecia areata has a very classic appearance to it. All right, you're going to get these circular patches of hair loss that are going to be smooth, okay? Or you're going to see exclamation point hairs, okay? And we'll talk about what that is in just a second. All right, but it's going to look just like this. So this is a pretty, I would say, more of like a severe presentation, okay, of alopecia areata. Sometimes you can have an individual who just has a single patch of hair loss, okay? Sometimes you can have someone who has more than that. And this individual, they obviously have more, but it looks like they have areas that kind of coalesce together and have these larger patches, okay? Sometimes the patches of hair loss can spontaneously just start growing hair again and resolve, all right? And that can be the end of it. or you could have one area resolve and then another area start. It really depends person to person. Okay. All right. Now, again, in these patches, it can either be smooth or you can see exclamation point hairs. That's what this is pointing to here. All right, that's an exclamation point hair. I'm saying it again because you guys got to remember exclamation point hair for alopecia areata. Because guess who's going to ask you about it?
You.
And yes. All right, so it's a good detail to know to help you guys remember this condition. All right. So what is an exclamation point hair? It's a hair that's going to have normal caliber at the top, okay, at the distal end, and then it's going to taper as you get closer to the scalp getting smaller. All right. Why does this happen? Well, with this immune condition, you're going to have CD8 cells that are going to attack the hair follicle, okay? And it's going to cause the hair follicles to go from anagen to catagen to telogen very quickly, and then back into a dystrophic anagen phase where the hair follicle is not going to grow to its normal caliber. All right. So when you're looking at these hairs, normal caliber is happening towards the top because this process wasn't happening then. All right. So that hair was able to grow normally. As you get closer to the scalp, it starts to thin because it was in a dystrophic follicle. All right. So it's just going to be smaller caliber. Okay. Does that make sense? Yeah. Yeah. Okay. All right. So exclamation point here, something to look for. All right. Now, with alopecia areata, typically this is non-scarring. Your patient is going to get their hair back. All right. There's a couple of circumstances where that may not be true. All right. If your patient hasn't had hair growth back in 2 years' time, likely they're not getting it back. If they got this very young and they've had multiple recurrences, okay, then less of, it's a poor prognosis, I should say. All right. If they have a family history, that would be another like poor prognostic feature. And if they have autoimmune disease, okay, there's some that kind of run along with alopecia areata, and we'll talk about that. All right. But that would be another reason. Okay. Or if they have a very severe presentation, and that is this picture here, okay? So you could get something called alopecia areata totalis. This is where someone loses all of the hair on their scalp, okay? You could also have something called alopecia areata universalis, where they lose all of the hair on their scalp and then also on their body, okay? This would be a poor prognostic feature, okay? It's not very common. Not to say that their hair can't come back. It does sometimes. Okay, but then also sometimes it doesn't. Other person. So alopecia areata totalis is going to be in like less than 5% of the population. Universalis is going to be less than 1%. Right. Another poor prognostic feature too would be if there's nail pitting. Okay, that's something that you can see. All right, with this condition. Okay. This is where it's not just affecting the hairs, but it's also affecting the nail. Okay. All right. So associated autoimmune diseases. So Addison, okay, thyroid disease, SLE, atopic derm, and vitiligo, okay, can all happen concomitantly with this. And if it does, again, for a prognostic feature, in about 10 to 25% of individuals will have this, okay, another underlying autoimmune condition. All right, thyroid disease is one of the most common, okay? It's something you should actually screen your patients for. So, not to say you can't also screen them for the others, you can, but thyroid disease for sure, all right? And that's hypo, hyper, okay, thyroidism. It can happen at the same time the alopecia areata is occurring. It can start a little bit before, okay? And sometimes it can even happen later on during the course of the disease. So you might do some blood work to just check your patient and then just ask them questions for symptoms and stuff like that as you were treating them, okay? All right. Okay, so patient symptoms, there's really no symptoms, okay? Oh, actually, I want to jump back to this picture here. I just remembered something I wanted to share with you guys. When hair regrowth happens, okay, if you look really closely at this picture, it looks like a little fuzzy on like the edges of the patches. You guys kind of see that a little bit? It looks like a little white fuzzy. The hairs grow back white typically, all right? So if you happen to have a patient who has this, Don't be alarmed, that does happen. It's just the melanocytes are a little sluggish to get going. They will get going and the hair will repigment, but that's just something you might notice, okay? All right, back to where we were. Okay, so no symptoms, okay? It's just going to be present, all right? Which of course is going to induce anxiety again in your patient. Diagnosis is going to be clinical. You're going to ask the history. Has there been anything, substantial that has happened in their life, any change, okay? They confirm that. That's obviously going to help back up your suspicion, all right? You're going to, you don't really have to do a punch biopsy, okay? If you see it and you recognize it, then it's clinical and that's the end of it. If you're unsure, obviously you can, all right? And then you're going to run some blood work, all right? So again, you have to check that TSH. But you'll also check RPR. Okay, I want to bring this up too. So RPR is for what? No. It's a condition that we talked about in a prior lecture. It can cause a multi-in appearance of hair loss. RPR is a rapid process. Oh, syphilis, yes. Remember that, okay? So you're gonna wanna check an RPR too because you can get that multi-in pattern of hair loss, which can mimic alopecia areata, okay? You'll check your ANA, all right, also for any autoimmune disease, and then their vitamins, iron panel, okay, and so on. All right, so treatment for alopecia areata, ILK injections, all right? It's going to be your usual mainstay for this condition, okay? I guess I should say the dilution or the strength of the steroid that you're going to inject into your patient depends on the area that is affected, all right? And you guys will learn that in clinical practice, but you're going to pick a stronger dilution for the scalp because it can tolerate side effects better, okay? You're going to go a little bit lighter on the face, all right? So like maybe 2 milligrams or so, all right? But again, you guys will learn that as you practice, okay? I don't expect you to know that, but just so you're practicing, okay? Your patient's going to come for ILK injections, usually around like every 4 to 6 weeks or so, okay, for repeat treatment. It takes time, okay, to see that hair regrowth. If your patient is not able to tolerate ILK injections, this is where you're going to consider topical steroids, okay? It's not the one that you're going to really run to because it's a little less effective, okay? It takes a little bit longer, but you might use it for someone maybe who has a needle phobia or for like a pediatric patient, okay? Hair pieces, wigs can also be utilized. Hair regrowth usually happens in 6 months. And then again, psychological support is important. Recurrences can happen, and we talked about the prognostic features that are important. Okay, telogen effluvium. So telogen effluvium is going to be temporary hair loss that can be, it can be pretty extensive, okay, in your patients, all right? So these are patients who are certainly going to come in very anxious about their hair loss. They're going to have diffuse hair loss throughout their scalp, okay? Now, telogen effluvium, the way that it occurs is usually after a shock to the body. So this could be an illness, okay? It could be a trauma. Sometimes this happens after pregnancy, all right? It's not uncommon, okay? Now, what happens with telogen effluvium is there's a shock to the body, right? It pushes the hairs that were in anagen right into telogen, okay? And it changes the ratio of hairs that we have in anagen and telogen. So we know that in anagen, you have about 85 to 90% of your hair typically unaffected, right, by this condition in that phase, right? When that shock happens, about 70% of those are going to go into telogen now, okay, as opposed to that 5 to 10%, all right? Now, your body's just kind of essentially trying to divert resources away from the hair because that's less important than whatever's happening within their body. That's why this occurs, all right? The hair loss that you see happens 3 months after that event, okay? Because how long is telogen? How long is that phase? About 3 months, okay? So all of those telogen hairs are just hanging out. 3 months happens, okay? They come to the end of that phase. Exogen happens, anagen's, starting to reoccur, and all those hairs get pushed down. So you can imagine now your patient sitting there and 70% of their hair potentially is now just coming out at the same time. All right, they're going to be very anxious about this. Okay. But you have to tell them, although this is kind of scary that all your hair is coming out, it's actually a good thing. Okay. It's telling us that anagen has restarted and all the hair that fell out is now regrowing. Okay. It's just going to take time. All right. Okay. So when you see telogen effluvium, it's going to look, it's hard to capture in a picture, right? You just see this one side of their head, but it's going to look just like this where you have diffuse hair loss, and no matter which way you turn this patient's head, it's going to look the same all the way around. Okay. All right. This is going to have a very positive pull test. You're going to go like this to your patient's hair, and then it's just going to cover it out. Okay, lots of hairs. Okay, that's just telogen hairs which just easily shed. All right, so just going to pull right out. All right, you can also see Bose lines, right, where you have an arrest of the nail matrix. Okay, and you get that horizontal depression across the nail that happens after a shock as well. Okay, we'll talk more about that later. All right, the etiology for this is going to be variable. It can affect anyone. Okay, diagnosis is truly going to be clinical. All right, you're going to get the history, find out about the shock or the trauma or whatever that happened. It's going to just add up. Okay, you'll do your pull test if you feel like you need to. Okay, and then that's going to be again very positive. You could look at some of those hairs underneath the microscope and see that a lot of them are in the telogen phase. Okay. If you're unsure, obviously you could do a biopsy. It's going to come back that there's a lot of telogen hairs. Okay. You could do some blood work, or if you're really unsure, you just want to rule out everything else. Okay, but you're probably not going to. Okay. So treatment for this, I would say it's just time, patience, and support. Okay, being there for your patient, letting them know hair will regrow in about 6 to 9 months. Okay, in the meantime, just be gentle with your hair. Don't put it up, don't brush it aggressively, don't do anything, just leave it alone so that we don't pull out some of those hairs that are just sitting in telogen before we have to and kind of make the hair loss look worse than it is. Okay, just leave it alone. All right. Now, sometimes there can be an underlying cause to telogen effluvium that is persistent. Okay, maybe they have some sort of illness that's constantly causing this shock to their system. You could work them on for some surgery for that. That's unlikely. That doesn't usually happen. It's just a one-time event. Okay. Traction alopecia. So this is going to be hair loss because of traction on the scalp. All right. So this is going to be someone who wears their hair up maybe in like a tight ponytail or bun. Okay. Or maybe they, put braids in their hair. Okay. That are pulling traction on those hair follicles. Or maybe they have hair extensions in, okay, that are weighing down on the hair, okay? Or they have just very long hair that's heavy, right? That's going to pull traction. All right, and with that, you can see hair loss. Usually you'll have retention of the frontal hairline. This is called fringe sign, all right, where this remains, but then behind that you have more, diffuse hair loss. Now, the presentation is going to be variable depending on what your patient is doing with their hair. If they only have braids on one side of their head and that's how they complete their hair, they're only going to have traction now there. What did I say? Sounds like they're having a conversation. All right. Anyway, so depends on what they do. All right. It's only on one side that they're, doing braids. They're only going to get hair loss on that one side. All right. Now, this typically is not scarring, okay? But it can be if your patient doesn't stop the behavior. They don't stop whatever hairstyle they are doing. Eventually, you can pull enough traction and cause enough inflammation on those hair follicles that they will just eventually be destroyed, okay? In that case, they may have to consider getting a hair transplant, okay? But for everyone else, okay, but, basically the directions you want to give them, okay, the patient education you want to give them is stop doing whatever the hairstyle is, okay? Change it up, let the hairs relax, okay? Gentle hair care, right? Can I explain that? What? Oh, fringe sign, sure. So fringe sign is just where you have like retention of the frontal hairline, okay? And then behind that, that's where you have just because those hairs are usually smaller, finer, they're hard to grab and put into that hairstyle, so they're not going to be affected by it. Okay. Okay. Let's see. Trichotillomania. So trichotillomania is going to be a, basically it's a type of hair loss because someone is compulsively pulling their hair. Exactly. And this is part of the DSM-5 criteria, okay, for OCD. And what you see in your patient is going to be dependent, again, on what they are doing. So, having audio issues. All right. If your patient is pulling a lot of hair, okay, that's going to be represented on their scalp. Sometimes you can see that. Sometimes it could be just like a small patch, okay, where they're just pulling a little area out. Sometimes also with the yeah, definitely not. In addition to those areas of hair loss, something else you might notice is like picked out crusted areas because your patient might not just pull their hair, but they might also pick at their scalp. All right, part of this compulsive disorder. So if someone has this, okay, it might be that they're doing it because it's like an anxiety stress reliever, okay, and that's causing them to pull out their hair. For others, it might just be that they're playing with their hair and they feel that some hairs have a slightly different texture than others, and they don't like a certain texture, they pull those hairs out. And sometimes it's just like an unconscious habit. So someone might be just watching TV or studying or something like that, and they don't realize it, and it like feels good to them, and they're just sitting there and they're just pulling out their hair. Okay. So there's a couple of different reasons why someone might do this. A complication to it is some people will not only just pull their hair, but they might also eat it. Okay, I don't think that's the unconscious person who's studying and like watching TV. I don't think they're pulling it and eating it, but maybe the person who's like aggressively just trying to remove their hair and they're stressed or whatever. You know, there's maybe a little bit more of a psych disorder that might be happening with that patient. They're eating it, and it's called a triple bizarre, where you can get an obstruction, okay, in the intestine. Okay, so it can look like a small bowel obstruction as part of this. Okay, so this is a diagnosis of exclusion. You're going to want to rule out everything else before you give your patient this diagnosis, except if they come in and they say, yes, I like to pull out my hair. Okay, that's pretty straightforward in that case. You don't have to rule out anything else. Treatment for this is going to be reassurance. Okay, stop pulling the hair, and you're going to refer them to psych, okay, for cognitive behavioral therapy. All right, okay. Nail disorders. So we have the anatomy of the nail. So I'm just going to go over this with you guys real quick. So you have your proximal and lateral nail folds, okay, on either side of the nail plate. The nail plate is going to be made up of hard keratin, okay, that's going to come from keratinocytes derived in the nail matrix, which is directly below that proximal nail fold, okay. You can see a visible part of the nail matrix if you look down at your own nail. It looks like that little half moon area. This is called the uvula. You can also have, I think I totally just nailed it, but you can also have something. You can have a cuticle, all right? You should have a cuticle. So cuticle is just a layer of basically dead skin cells that's going to attach the nail plate to your skin, okay? So, yeah, don't pick it out.
I'm saying like when they clean your nails, like
Yeah, tell them to go alone. Don't touch it. Yeah. The reason for that, right? So it acts as a barrier, okay? So that this way pathogens and everything doesn't get in. It kind of just seals your nail plate to your skin. So tell them to go to get your, leave it. All right? Okay. The nail bed is an extension of the epidermis, okay? And then you have your hyponychium. So the hyponychium is basically the skin underneath your nail plate at like the very end, okay, where it attaches. Sometimes you rip that, okay, and it hurts pretty bad. That's your hyponychium, okay, that you've damaged. All right. Okay. Onycholysis. So onycholysis is going to be where you have a detachment of the nail plate at the distal and lateral edges. Okay, so this area here that's affected, this nail plate is no longer attached to the nail bed. It looks white, okay, or sometimes kind of yellow in appearance, and it's just lifted off the skin. So this can happen for a variety of different reasons. Is everybody okay? Was it a spider?
Oh,
It's just a bug. Oh, there. You have to take care of it. Keep it down there.
there.
So with onycholysis, what's happening in here today, huh? Spiders, I am the, yeah. Anyway, um, this can happen for a variety of different reasons, okay? You can have onycholysis because your patient's coming into contact with like detergents or solvents that are damaging the nail and the underlying nail bed, all right? It can happen because of trauma. It can also happen because of getting your nails done, okay? Getting manicures. So all those tools that they use to scrape and clean and manipulate your nails can damage the nail bed over time. If it's bad enough, you can have scarring and the nail bed will no longer attach to the nail plate. This becomes a permanent process, okay? So all of you out there who like to get your nails done, okay? And your own nails at home, all right? Instead of using all of those tools and everything that they do because it can traumatize your nail, all right? And you'll see why. The next slide, okay, the next pathology, you might also not want to do that so much. Okay, so treatment for this. Debride all the nails, clean out underneath them, keep them short, and keep them dry, okay? But again, once this becomes permanent, that's it. Problem. Green nail syndrome, okay, caused by Pseudomonas, okay? So we see this a lot with onycholytic nails, where Pseudomonas takes up residence, okay, and can cause infection of the nail plate, and it produces a pigment called pyocyanin, which turns to milk, okay? Now, this is treatable, okay, but it takes a long time, okay? So another reason not to get your nails done, you want to avoid this, okay? You might also want to avoid fungal infections that can get underneath there as well, okay? All right. So treatment for green nail syndrome is going to be keeping the nail short, keeping them dry, okay? And then there's certain topicals that you can use. Usually they have to be used for about a month, all right? So treatment takes a little while, all right? One of your options would be polymyxin B or bacitracin. This is going to be applied 2 to 4 times a day, okay, for the duration of that month to the nail, okay? Another option would be ciprofloxacin, okay? So this comes in a solution, usually like an odd solution. That's how you're going to prescribe it, okay? But you're going to put in the directions, apply to nail. All right. Sometimes the pharmacy will call you and they say, this is for the ear. Why are you telling your patient to use this for their nail? The patient knows, okay, what the plan is. All right. So they're just going to be applying, all right, as directed. Okay. Acute and chronic paronychia. So we'll talk about them kind of like separately and then together. First, we'll talk about acute paronychia. So acute paronychia, actually, I should say paronychia in general. It's going to be either due to inflammation or infection. All right. For acute paronychia, it's going to be both, but mostly due to infection. All right. Now, the reason that someone can get this paronychia could be because they had a trauma to the area, right? And that caused the break in the skin that allowed the bacteria in. Could be a foreign body, maybe like a splinter. All right. It could be someone who likes to bite on their cuticles and rip them off. All right. Introducing oral flora into the area. All right. Could also be from getting your nails done and they didn't clean their equipment. Okay. And then they introduce bacteria when they cause a little break in the skin. Okay. Either way, more often than not, it's going to be caused by Staph aureus. Okay. And it's usually going to affect one finger. All right. And it's going to affect most often just like one nail fold, okay? Sometimes you can get it where it affects not just the proximal nail fold, but both lateral ones. You can get what they call runaround paronychia. That would be obviously more of a severe presentation, but something you might see. Your patients can have all the cardinal signs of inflammation, okay? And sometimes you can see like a little area of pus where the paronychia is occurring, right? And likely they're going to have, you know, throbbing sort of pains that area. All right. For chronic paronychia, so this is going to affect usually all nail fold, proximal nail folds, okay? This is going to be someone who does dishes a lot or comes into contact with detergents or solvents. So maybe it's someone, you know, who's a house cleaner or someone who's handling food a lot, all right? They're going to be more susceptible to chronic paronychia. This is not due to infection. This is going to be purely inflammatory. Okay, can get secondarily infected, but the underlying process is just inflammatory. All right. Now with this, they come into contact with those chemicals, those solvents. It's going to irritate, cause inflammation. Okay, that's going to affect that proximal nail fold, and you're gonna see changes with that to the area. So, the nail fold over time is going to be thicker, okay? It's gonna cause hypertrophy of that proximal nail fold. They're going to lose their cuticle, and you're going to see longitudinal ridging down the nail plate, all right? There are usually no symptoms that come along with this. It's just the change in their nails that your patient's gonna see, and that's what's gonna drive them to come in, okay? All right. With chronic paronychia, so common secondary infection could be Candida albicans or sometimes Pseudomonas, okay? All right. We pretty much covered everything here. The only thing I want to mention is whether it's acute or chronic paronychia, it's a clinical diagnosis. If you suspect that there's infection, obviously you're going to do a culture that comes along with that, okay? Whether it's bacterial or fungal, depending on the situation, right? Okay, so treatment for this. So if you have an acute paronychia and there is no abscess and it's relatively mild, say affecting only one nail fold, all right, you're going to recommend warm water soaks with an antiseptic in it, okay? And they're going to do this usually like 10 to 15 minutes at a time, a few times a day. That should be enough. You might also give them like a topical mupirocin to apply, okay? If it's more of a moderate presentation, so it's affecting maybe more than one nail fold, okay, then you're going to consider oral antibiotics. All right, so classic ones would be like a Keflex or cephalexin or dicloxacillin to treat that staph. All right, if they're nail biting, you have to consider oral flora. Okay, so then in that case, you're looking at augmentin or clindamycin. If you suspect that this is related to MRSA, then it's doxy, clinda, or Bactrim. Okay. Now, if they have a chronic paronychia, right, because this is usually more inflammatory, protection is going to be key, okay, from those irritating solvents, chemicals, whatever it is they're coming into contact with. So wearing rubber gloves with a cotton lining is going to be recommended, okay? The cotton lining is less sensitizing than the rubber itself, so that's why you recommend, okay? Less irritating on the skin. For treating that proximal nail fold, it's going to be topical steroids, usually a high potency, like a basal, okay? You can consider tacrolimus. You can also consider ILK injections right into that proximal nail fold. That hurts, okay? But it's something that you might consider in someone who has more of a severe presentation, okay? Topical antifungals, if you think there's a more mild, fungal infection going on. If it's more severe, then obviously you're going to give them something oral by mouth. Okay, so in that case, you're looking at fluconazole or diclofenac. All right. You might have to then also consider ciprofloxacin if you think this is a pseudomonal infection. So depends on what you're okay. Felon. So a felon is going to be basically an infection of the finger at the distal pulse. So this is your finger pad. Okay. This can happen for a variety of different reasons. It could be because a foreign body got stuck, okay, in someone's finger pad. It could be that there was some sort of penetrating trauma, or it can happen because they had a paronychia acutely, all right, that was untreated, okay, and then over time the infection spread and went to the finger pad, okay. This is something when you see it, you have to treat it, okay. If you look at this picture here, what I wanted to show you guys is where the infection is occurring in the finger pad, there's always like little compartments, okay? It's a tight space. And when the infection happens, it's going to cause inflammation to that area. There's little vasculature there, okay? Like tiny vessels, all right? And those vessels can become compromised and it can lead to necrosis, okay? Their finger pad, right? So you want to treat it right away when you see it so that doesn't happen, okay? With worsening infection too, this is not too far from the bone, so it can cause osteomyelitis. The infection can also easily move down to tendons, affect that. It can also move to the joint, and you can have like a septic arthritis. So you got to treat it, okay? All the cardinal signs of inflammation are going to be there. This is going to have pretty severe pain, okay? Especially if your patient has their hand in the dependent position, all right? They're going to have like pretty intense throbbing, all right? The common cause behind this is usually Staph aureus, okay? Now, for most common areas affected, usually the finger and the index finger and the thumb, all right? Just because those areas are more susceptible to trauma, because we use them the most for like manipulating things around us, okay? Treatment. So if it is fluctuant, then it's going to be an IND. You'll put your patient on antibiotics, okay? You'll do your culture at that time. If there is no fluctuance and it's early, okay, so no abscess formation, then it's going to be warm water soaks, elevation, and then you're going to empirically put them on an antibiotic, okay? Usually something to cover for that Staph aureus, all right? So like a Capsulex or Cephalexin or dicoxazole, okay? All right. Onychobrexit. So this is going to be longitudinal ridging down the nail plate. All right. Sometimes this just happens with age. Okay. And sometimes it happens because people pick. All right. That's what it looks like. And I don't have anything else to say about it. Okay. Moving on. Median nail dystrophy. So median nail dystrophy is going to be caused most commonly by someone who's doing this. They're picking at their proximal nail folds on their thumb. Okay, and it's causing a defect in the nail matrix below that proximal nail. Okay, so when that happens, they're going to get this groove that goes down the nail plate. Okay, and it's going to have these like little cracked fissures kind of angling back. All right, going down it as well. It's supposed to look like a inverted fir tree. Okay, if you guys are familiar with what a fir tree looks like. Now, treatment for this, stop picking, okay? So what you might recommend to your patient is to bandage their thumbs, right? So that this way they can't pick, blocks them from doing it, all right? It's also a helpful thing to do because those little fissures and cracks that occur sometimes catch on clothing and things, and that's annoying. So if you bandage it, then it won't catch, okay? So kind of like a little helpful thing for them to do. You're not really going to do a psych consult unless your patient has like other things going. Maybe they're also pulling their hair out compulsively or something like that. All right. But for, let's see, your routine patient, you're not going to do that. Okay. All right. Other treatment options. So you can do ILK injections again into that proximal nail fold. You can consider topical steroids or those calcium urine inhibitors like tacrolimus. You could also consider Tazorac, okay, which we know is a topical retinoid, all right? So retinoids help with basically modulating keratinocyte proliferation and differentiation, okay? It helps just regulate them, okay? So we're treating the nail matrix where those keratinocytes are. It's going to help regulate them, help the nail grow out more normally, okay? All right. Pincer nail deformity. So this is going to be basically an individual whose nail plate is curving in, okay, at the lateral edges. All right. It's not really well understood why this happens. We think it might have to do more often than not with like compressive shoes. Their shoes are too tight, puts pressure on the nail and causes it to kind of bend in. All right, but you can also see this on fingernail, okay, as well as toenail. And the degree to which the nail is affected is kind of variable nail to nail. So you can see that this nail is more affected than this one and so on, okay? There's not really a whole lot you can do for this condition. You could, if it's affecting the toenails, recommend that your patient wear proper fitting shoes, okay, nothing that's causing compression. You could send them to podiatry and they can apply a brace across the nail that just kind of helps lift it. Caveat to that is once the brace is gone, the nail is going to go back to that shape, okay? If your patient doesn't want to deal with this problem anymore, something that podiatry could do is actually remove the nail, okay? And scar up the nail matrix so that the nail does not come back. So they just don't have a nail anymore, okay? They don't actually need it, okay? So it's an option for them. Right? Okay. Bowlines. So bowlines are basically where you have an arrest in the nail matrix because of shock to the system, okay, which is going to cause a horizontal depression across the nail plate. So that shock, again, could be a variety of different things, infection, malignancy, all right, could be due to trauma, all right. Sometimes you can have bowlines that affect just a single nail, and it could be because the trauma happened to that one finger. All right, but more often than not, it's going to affect more nails, okay? It's gonna be more of a systemic cause, okay? Sometimes you can even have multiple bowlines spaced out on someone's nail. This could be someone who's going through chemotherapy at regular intervals, okay? And it's gonna cause this shock to keep recurring, okay? You can see that. What's kind of neat about a bowline is that you can tell when the shock occurred, okay? When you look down at their nail and you look at the placement of the bowline. So if I know that under normal circumstances, okay, it takes a nail plate about 6 months on the fingers to grow from the proximal end to the free edge, okay, and their bowline is happening right in the middle. Their shock probably happened about 3 months ago, okay, having at the halfway point. So it's kind of neat for tracking, you know, when their shock occurred. All right. Okay. If the nail matrix is affected for 7 to 14 days, you can get something called onychodesis, which is a total division of the nail plate. All right. This is a different condition, and it's very common in children. Okay, especially after like Coxsackie. All right, they get the virus, and then oftentimes what will happen is the parent will bring them in, okay, at a later date after they're feeling better, and they're going to say, I think my kid has a fungal infection. All right, and it's going to look similar to this, the nail. All right, but what's actually happening is there's a division in the nail plate. This area is lifted, so the nail takes on like a yellow-white kind of discoloration to it, which someone else might look like a fungal infection. All right, but you're going to go over and you're going to touch the nail. You're going to see that it's starting to come off. You're going to ask, were they recently sick not too long ago? The parent's going to say yes, and they're going to say this is onychodesis. Okay, it's just an infection affected the nail matrix for a long enough time that it actually cleaved the nail plate. Okay, that will grow out. Okay, as will both lines. All right, their nails just going to grow naturally. Okay, and for treatment, there's really nothing you have to do. Just let it run its course. Okay. All right. Benign melanechia. So benign melanechia is where you have sudden activation, essentially, of the melanocytes in the nail matrix, which are typically inactive. Okay, so they're starting to produce pigment. So this is something that you can see that usually affects multiple nails on individuals with a darker skin complexion. Okay, so like the African American population or Hispanic population, sometimes the Japanese population too, will just have these bands that go down their nail, okay, that are tan, brown, or even sometimes they're like a dark brown in color. Okay, it's just normal, okay, and it's nothing to worry about. It's benign. All right. However, if you're looking at someone's nail, all right, and they have a band, but it's only affecting one finger, I would be more suspicious of a melanoma, and that's something I want to rule out, okay? Especially if it's affecting the thumb, all right? When a melanoma occurs, okay, and it affects the nail, it's going to be usually there's going to be history of a band that's changing color, it's changing size over time. That's going to be part of your history. That's going to be important, okay? If you suspect a melanoma in your patient, you got to do a biopsy and rule it out. All right, with benign melanechia, multiple nails are going to be affected. All right, there's going to be no history of change in the band size or color. Okay, make sense? Yeah. Okay. All right. Hub nails. I'm sure you guys have heard of this before. So this is where you have someone who has a bulbous enlargement of their distal phalange, usually related to underlying disorders like what? COPD. So usually like a respiratory illness, okay? Sometimes we can see this with cardiac illnesses and then rarely with GI, all right? Now, with that bulbous enlargement, okay, the distal part of their finger, they're also going to have a change in their nail. And along with that, it's going to become broader and more curved, okay? This usually affects all of the nails, okay? Now, for treatment for this, usually there's not much you can do, but if you catch someone's underlying disease early in the process and the tissue hasn't really changed that much yet, and you treat their underlying cause, you can reverse this, all right? But more often people are coming in and it's already been kind of chronic and the changes are already there. It just kind of gets with it. Okay. All right, polyonychia. So this is going to be where you have spoon-shaped nails. So there's going to be a depression in the center of the nail plate with elevation of the lateral edges. Okay, so like a little spoon. This can be a natural variant in some individuals, or it can be due to an underlying disorder like iron deficiency anemia. Okay, so if you see this in your patient, you're going to want to work them up for sure for iron deficiency anemia. If that is treated, this will go away. Okay, all right. There are other causes too, but that's really the most common one. Okay. Pterygium. So pterygium is going to be where you have scarring that's going to affect the nail bed coming from the nail matrix, and it creates like a V shape as it travels down the nail bed. Okay, just like what you're seeing here. Okay, and then it kind of continues on. So with this, it's a condition that you oftentimes will see with like lichen planus. Okay, it affects usually all 20 nails, and when it's severe enough and untreated, it will eventually destroy the nail, and then there's no getting it back. Okay. If you catch it and it's treatable, so you can do ILK injections again right into that proximal nail fold. Okay, topical steroids can also be utilized, but I'd say ILK is really what you're going to lean towards first. It just targets the area a little bit better, okay, than using topical. Yellow nail syndrome. So yellow nail syndrome is going to be a condition where someone has yellow nails, okay, that are going to be very brittle. They're going to be curved. There's going to be no cuticle with them. It's going to affect all of the nails. Okay, and this is going to be due to the nail either growing very, very, very slowly or not growing at all. Okay, it's oftentimes associated with lymphedema and some underlying respiratory illness. Okay, treatment for this. So usually there's not a whole lot you can do. All right, there are some things you can try that have worked sometimes for some patients. All right, but not very reliably. But vitamin E solution can be applied topically to the nails, and that's supposed to help. We have no idea why. Okay, I'm not even sure who did it first, but somebody tried it, and sometimes it helps. Okay, so it's something you can consider. Itraconazole. So this is not fungal at all, but itraconazole has shown to help with nail growth and causing nails to grow a little bit better. So for that reason, it can help, stimulate the nail matrix to start growing and hopefully alleviate this condition. All right. Refer to a PCP. So if your patient comes in and you've asked them, do they have a history of respiratory illnesses, and you kind of go through that with them and they say no, then you're going to want to refer them to the PCP for a workup because there's probably something else going on, okay, that's causing this. All right. More often than not, patients are going to come in with that medical history anyway. Okay. All right. Hyperhidrosis. Last one. So hyperhidrosis is where you have excessive sweating outside of what you need for thermal regulation. So this is going to affect usually the axilla, the palms, and the soles of the feet, sometimes also the forehead. All right. So this condition can be problematic for your patients, okay, especially on a daily basis, professionally. All right. Individuals who have this and they're sweating often, okay, might sweat through their clothing, that they have to bring extra pairs of clothing with them throughout the day. That can be cumbersome and, psychologically can be challenging for them. All right. I also think of someone maybe who has very sweaty hands and they're handling paperwork. It might soil the paperwork, or they have to shake hands. It can be uncomfortable for them. Right. So, want to make sure you take time to counsel these patients too when needed. All right. So usually there's some sort of like emotional trigger, some sort of stressor that's going to bring about sweating. All right. So just something to be aware of. Now, treatment for this is going to be antiperspirants. So that can be over the counter. All right. Clinical strength ones. They can try to utilize those. Or you could give your patient a prescription antiperspirant. All right. So this would be like aluminum chloride hexahydrate. All right. 20%. So with this, with any antiperspirant, basically what your patient's doing is applying a metal salt, okay, that's going to physically obstruct the sweat gland and stop producing sweat. All right, it takes a little bit of time for these medications to be effective, but it's something that you can consider for your patient. with the aluminum chloride hexahydrate, you want to tell your patients, especially they usually use this under the axilla, to make sure that their skin is cool and dry before applying it. If they apply it to wet skin, sometimes it can cause an irritation. Other options, glycopyrronium. So this is an anticholinergic medication. It comes in a little wipe, all right, that your patient can apply to the affected area. All right. Side effects, anticholinergic effects. All right. You want to tell your patients to definitely wash their hands after using this medication. Don't touch their eyes. All right. Photoparesis. Okay, so this is going to be where basically your patient is going to submerge, whether it's their hands, their feet, or even they have specialized trays for the axilla. They're going to submit their affected area into a tray with water that has electrodes. It's just tap water. It's going to send ionized particles through their skin, and it's going to disrupt the sweat glands, okay, and block them. It's a cumbersome treatment. Sometimes your patients have to do this like every day, 20 to 30 minutes at a time. All right, sometimes it's a couple of times a week. All right, depends on what's going on with your patient. That's something that they can do. It is pretty effective. If it's not working well for your patient, you can give them glycopyrronium tablets so they can brush and put into the water so they get the benefit of that medication as well. All right. And then outside of that, it's going to be Botox. Okay. So this is going to be injected into the affected area. Basically, Botox is going to block acetylcholine, all right, which is the neurotransmitter needed to cause sweat glands to produce sweat. Okay, so it's going to block that. It works well. All right. Usually can get it covered by insurance, but sometimes you have to try the other